Hi there. Welcome back to Week 8. In this lecture, we're going to talk about practical issues in designing and managing both clinical and health services research projects. Some of the practical issues that we're going to consider are the determination of sample size, called power analysis, the recruitment of research participants, how you get people into your study, the critical issue of defining the role of your participants. And there are two roles that we need to consider. They're playing this dual role, both as patients in a treatment program, as well as research participants in a research program. We need to deal with compliance issues, people coming back for their treatment, but also compliance with research follow-ups. And then there are other issues having to do with how many follow-ups you want to conduct and how to deal with intoxicated research participants. So let's get started. Statistical issues are paramount at the beginning of a trial in the planning phase because we need to determine how many people to include in our study. If it's a naturalistic study of an existing program, we still need to estimate how many people we need to follow up in order to make valid conclusions about the expected effect of the treatment. Usually this involves consultation with a statistician, although there are cookbook methods of estimating sample size through what is called power analysis that you can use by following YouTube videos and reading up on the subject in statistical books. These things are covered in more detail in another video that's listed as one of your assignments. But I just want to go over a few of the terms. One of them is the null hypothesis. The null hypothesis is the opposite of your real hypothesis, where you might expect differences between two groups or differences prior from baseline to follow-up. The null hypothesis is the prediction that there is no difference between groups. And ultimately what you want to do when you're designing a study is to design a powerful enough intervention so that you can reject the null hypothesis of no difference between the treatment and control group or between the people exposed to treatment A versus treatment B in a comparative effectiveness trial, or differences between program A and program B in a program evaluation study. Another term that's important is significance level. And as you've undoubtedly become familiar with in a course on statistics, generally the significance level is set at 0.05 or 0.01. These traditional values determine the risk that you're willing to take in concluding that there is a real difference between groups when the difference is actually due to chance fluctuation. So 0.01 means that one time out of 100 in the sample that you've recruited, you're going to get a significant difference just by chance fluctuation. And if you set it at 0.05, that means you're willing to take a risk of 5 wrong conclusions out of 100. In some cases, when you're doing exploratory research, you can shift the significance level to 0.10, for example, to take even greater risk. It all depends on what risk you're willing to take, and you need to consult with your statistician to determine what that's going to be. Power is the probability that the results of your study will be statistically significant, and you will reject the null hypothesis when there is actually a real difference. The power level is set in advance. It's usually around 0.80, but if you want to be more conservative, you can change it depending on the risk that you're likely to take. Finally, the effect size is the size or the magnitude of the difference that you expect to find between two groups. This can be based on other studies that have shown in similar situations a large or small or medium difference between groups. You can also do a pilot study to find out what the likely effect size is going to be, or you can just set it at small, medium, and large. In all of these situations and making the decision to do a power analysis, it's wise to consult with a biostatistician and look at the YouTube video that we're recommending. Now let's get into recruitment strategies. Once you've established the number of participants that you're going to recruit based on the effect size that you expect, the probability level of rejecting the null hypothesis, and the power of your study, you need to go out and find research participants. Usually, research participants are not sampled randomly. They're sampled most often in treatment settings as samples of convenience. It's always good to try to get them selected randomly, but either case, the recruitment of your participants obviously is critical to the achievement of a representative sample. And what you want to do as best you can is recruit your participants in a way that reflects the type of people that you want to generalize to, or that who are actually participating in a given research program. If your sample is highly selective, then you can't generalize to the entire population. Therefore, you need to pay a lot of attention to refusal rates. We've heard a lot about follow-up rates. The refusal rate at the front end is the number of participants who refuse to participate after being asked. So if you're sampling patients and you provide an explanation of the study for every new admission to a treatment program, or everybody who calls into a telephone number where you've advertised for research participants, you need to document not only the people who agree to participate, but the people who either don't show up or who have decided not to participate after you have explained the study. You need to have as low a refusal rate as possible. The refusal rate depends on a variety of things, and one of the biggest things is your inclusion and exclusion criteria. In advance, you need to establish which patients you want to generalize to and recruit into your study, and which patients may have to be excluded from your study for some obvious reasons. For example, age. If you want to generalize to adults, you need to select an age cutoff point. Often that's set at 21 because at a lower age, you have to get parental permission. But you may also want to set an upper limit because there aren't too many patients who come into treatment over the age of 50 or 60. Another issue is gender. If you want to generalize to women, then you need to include women, but you may be testing a program that is only appropriate for women, so your inclusion criterion would be women. You want to make sure that the people that you select meet the criteria you've established for an appropriate diagnosis. And that means if you want to study alcohol dependence, you need to make sure that initially they meet criteria for an alcohol use disorder or alcohol dependence. You may want to include or exclude patients with psychiatric comorbidities. So that's another inclusion and exclusion criteria. Cognitive functioning may be important. If patients can't understand instructions, if their behavior has been clouded by withdrawal symptoms or dementia, then you may want to include that as an exclusion criterion. So your recruitment rate is going to be affected by your exclusion criteria, and you need to choose those criteria carefully. After you've established your inclusion and exclusion criteria, you need a strategy for recruiting patients. And this can be done in treatment studies by advertising in newspapers or advertising online, issuing a press release about your research project and giving a telephone number where people can call in. Often this is done in local newspapers. You can conduct a workshop for people who work in a recruitment assessment agency or a helpline or in a treatment program itself where they might be willing to refer patients to your research study. You could consider court mandates for DUI offenders. Sometimes people can go into treatment as an alternative to some sort of criminal justice sanction. Church bulletins, self-help networks, solicitation of treatment admissions who come into a particular program are all ways of advertising your program and getting them to the point where they're interested enough to listen to an explanation of the study and then sign up for it. Another thing that is becoming more popular, particularly for treatments delivered online, is online panels. And these are people who volunteer to participate in research. And sometimes they are quite good at following instructions and participating in a particular study. So don't ignore the possibility, if you're doing an online study, of using an online panel. And finally, you can use administrative data. You can check treatment admissions in a database that is collected or used by a treatment program to select people at random through telephone calls or through other ways to find out if they're interested in participating in your study. So now that you've begun to approach patients with an explanation of your study, you need to be prepared to explain to your participants what the study is all about. And there are two roles that need to be carefully designed in an explanation of your study. The first role is the role of a client or a patient. Obviously, this is the most important. And you need to give your clients or patients an explanation that defines what is expected of them when they go through your program. It's important for a variety of reasons, not only to standardize the message that all patients are getting, but also to make sure that your research participants are getting a sufficient dose of treatment in order for you to be able to observe an effect. So clients need to be given clear expectations about participating in the treatment program. And this is not unlike what would happen when somebody comes in for at the beginning of a program after they've decided to enroll. You need to review potential barriers. You need to explain how many sessions there are going to be. You need to warn them about the difficulties they're going to face, including relapse. You need to explain what happens if a relapse occurs. You need to take into account the possibility that they may be experiencing psychiatric symptoms and what to do about that, who to contact. You need to provide support and tell them where they can get support. And all the things that go into a comprehensive treatment program need to be explained in order to define the role of your participants as clients or patients in your program. Coming to treatment can be incentivized in some cases just to make sure people are getting a proper dose. And you want to make contact with significant others to make sure that their loved ones are being encouraged to take advantage of that particular research program. But you want to define it as naturally as possible by saying, here's what our research program is designed to do for you, and here's what you need to do to participate in this program as a client or a patient who's going to derive maximum benefit from it. There's a second role that needs to be explained, and it needs to be separated. We don't want the research participation to become a part of the treatment. So wherever possible, we need to separate the staff. People doing the follow-ups, for example, should not be the therapists who are encouraging patients to be abstinent. Patients may be reluctant to talk to their therapist about the fact that they had a slip when they could give that information to a research assistant who has guaranteed confidentiality and anonymity. So we need to explain to them that they're not only participating in the program, they're also participating in a study that is designed to help patients like them with optimal treatment. So you need to describe the research program, what's involved. This is usually done in an informed consent procedure that provides an explanation. But in some cases, you don't have to go into this amount of detail to explain where you expect your differences to occur, but because you don't want to sensitize the patients in your experimental group to help you to find a positive effect. You want to make sure that the treatment is being tested under conditions where the research study itself is not influencing the outcome. You need to review potential barriers, like what happens in a relapse. In the case of the research participation, a relapse is data. In the case of the treatment program, a relapse is a critical juncture in the treatment program itself, and they need to contact their therapist. But they shouldn't necessarily call up the research assistant to announce that they've just had a relapse. That comes when they are followed up at periodic intervals. The significant others around the research participant can be enlisted to provide external validation of self-report information. And we can reinforce compliance with coming back for follow-up evaluations through incentives. Sometimes it's monetary payments. In other cases, it may be other things that are valuable to a patient. Always use reminders to make sure that appointments are kept. There are a number of ways of reducing the barriers to participation by incentivizing research participants. You need to make sure that research participation is convenient. So hours need to be flexible. There needs to be transportation provided if people are traveling to come to a follow-up evaluation. Parking, cab fares, bus fares, taxi services are all important if you're doing face-to-face interviews. If you're doing telephone interviews, then you need to send reminders for appointments. Childcare during face-to-face assessments can be important, both at baseline and at follow-up. And obviously, convenient appointments, evenings, weekends, holidays. If people are working, you need to be very creative in making sure that your research participants know that you're interested in collecting not only accurate data, but complete data. Gratuities, often small gratuities, are effective in making the research participation valuable, interesting, and rewarding to patients, providing snacks, financial payments for the intake and follow-up assessments, and in some cases, a bonus at the end if patients or research participants complete all the follow-up evaluations. A big problem that occurs in follow-up evaluations is a client coming to an appointment and manifesting signs of intoxication. In some cases, it's written into the protocol that a breathalyzer test be taken at that time. And if it's done for everybody on a regular basis, then the research participant can be given the feedback. Or if they appear to be intoxicated, then you don't have valid information to present them with, and you don't want to get into a situation where you're arguing with patients about whether they're not or not they're intoxicated. In cases where you don't have a breathalyzer reading, you need to explain that it's unfortunate, you cannot go forward with the interview because it appears that you may be intoxicated. And in that case, the appointment is rescheduled. You need to avoid confrontation, offer help with referral if patients appear to be undergoing a serious relapse, and provide transportation if they appear to be intoxicated. Other compliance problems are encountered with follow-up evaluations. One problem is participants who are lost to follow-up. So you try to send them a reminder through email, or you call them up, and either a family member says that they've died or they've moved or they lost their telephone or become incarcerated. There are a variety of ways that people drop out of a study. And in cases like this, you can help to locate people by having collateral informants make themselves available at the beginning of the study just to find out, if you can't contact a participant, where to find them. You can also use records to find out if they've been incarcerated or they've moved or they've died. Another problem is resistant participants. They schedule an appointment and they don't show up. The solution here is to increase the incentives, provide flexibility, and to provide convenience for them, and to do what you can to find them in their local environment. Often interviews are scheduled at public places like a McDonald's, where people can come in and have an interview with a research assistant at a place that's close to where they live. Another problem is refusals who have gone through one or two follow-ups and finally decided they don't want to participate in the research anymore. You need to, first of all, make sure that they're not refusing to continue their participation because they've relapsed, in which case you provide assistance, ask them to contact their therapist or provide a referral through a self-help organization. The second thing you can do is respect the participant's decision not to continue their participation, but ask if you can revisit that decision later by calling them in a week or two. Another question that arises is how often you conduct your follow-ups. The longer the interval between baseline and the follow-up evaluation, particularly the interval between the end of treatment and your follow-up evaluations, the more difficult it becomes to find people. So you want generally to have a follow-up sequence that begins at the termination of treatment, when it is likely you can get 100% follow-up at the time people are ready to be discharged from an outpatient or a residential program. But you also want to set frequent intervals. And those intervals can be anywhere from 3 months to a year or 2 years afterwards.